Psydactic Residency Edition. I am Dr. O'Leary, and today is Wednesday, December 13th, 2023. This is a podcast primarily about psychiatry and neuroscience. I am currently a fourth-year psychiatry resident, and I make this podcast as a way to structure my own learning. Having a task to accomplish focuses me and makes me question and double-check myself. But I don't have an editorial staff to help me, and this podcast is no one else's opinion. That includes the federal government, the Department of Defense, the Defense Health Agency, or the Dill Pickle Club. A couple of episodes ago, I promised a more in-depth look at antipsychotic medications, also known as neuroleptics, but originally called major tranquilizers. However, I got distracted by a new study claiming to have reanalyzed the Tardive trial with very different results, so check out my last episode for this. Today I'm back on track, exploring antipsychotics. I thought it would be kind of a relatively easy topic, but the more I read, the more rabbit holes I discovered. Molecular biology and pharmacology can seem kind of like impossibly dense collections of facts. And if approached in this way, like just a bunch of facts, they certainly are impossibly dense. One thing that helps me is to approach it kind of from an inside-out way. If I can learn why all these different facts matter, how they relate to each other, then I'm much more likely to be able to remember each of them individually, so that relationship between them improves my recall of them. So I want to talk then about, antipsychotics and relationships that they have with a lot of the molecular parts of our body. To understand the antipsychotics and especially their side effects, I need to review some kind of pharmacodynamics. Pharmacodynamics is a word I use when I want listeners to get bored and skip the rest of the podcast. So if you plan to remain with me, welcome to the land of super nerds. Most of the doctors and student doctors listening will be familiar with the terms agonist and antagonist with respect to pharmacologic agents. An agonist is something that binds to a receptor on a cell and makes that receptor do more of something, like allow ions to flow in, or start sending a signal, or send more signal than it already is. An antagonist binds to a receptor, and it prevents an agonist from binding. So it effectively is keeping the receptor from being stimulated. But it's important to note that an antagonist actually doesn't change the basal rate of firing or the level of the ion flow regulated by the receptor itself. It just prevents the rate from changing. An antagonist not only blocks agonists, which would increase the rate, but also blocks inverse agonists. What are inverse agonists, Dr. O'Leary? Well, let's back up first and talk about the receptors themselves. There are many kinds of cell receptors, but they broadly do kind of three different things. This is an oversimplification, but it's helpful to think of it this way. Receptors either send a signal, open or close ion channels, or become enzymatically active, which means that they have a catalytic site and it becomes exposed when an agonist hits it, and whatever reaction it's supposed to facilitate starts to function. The dopamine receptors fall roughly into two of these categories. They either affect ion channels or they send signals into the cell. For example, there are like 5 basic types of dopamine receptors. They're called D1, D2, D3, D4, and D5. It's pretty simple. But it doesn't help me remember what each of them are. So to help me remember what type of receptor each is, I think of kind of a dopamine receptor sandwich. So the bread of the sandwich is D1 and D5. They're similar. They're both bread. And they're referred to as D1-like receptors. The D2, 3, 4 are like the meats in this sandwich. And they're often referred to as D2-like receptors. The bread, the D1 and D5, when agonized, they send a signal. They increase the production of cyclic AMP, which stimulates a long pathway that ultimately leads to increased transcription in the nucleus. So these D1-like receptors ultimately result in signals to the nucleus to make RNA that is later translated into proteins. The MEAT receptors, that second group, the D2-like receptors, when they're agonized, they reduce the production of cyclic AMP in it. So instead of increasing transcription, these receptors modulate ion concentrations, and the end result is activating potassium channels, which reduces the excitability of a neuron. This means that one of the functions of dopamine is to reduce the firing rate of the target neuron. If a neuron has a lot of D2 receptors and it's being hit by dopamine, it will basically do less of what it normally does. Often these D2 neurons are GABAergic. And so since GABA sends an inhibitory signal, that means that if you're inhibiting an inhibitory signal, you're disinhibiting something. Overall, the result is that the target of a GABAergic neuron will fire more if the GABAergic neuron is downregulated. Relationships like this are what make our brain capable of complex calculations. In general, the D2 through 4 receptors have a much higher affinity for dopamine than D1 and D5 receptors. What this means is that D2, 3, 4 receptors are more sensitive to small changes like in the tonic levels of dopamine, while the D1 and 5 receptors will respond more during like phasic dumps of lots of dopamine, which happens, say, when something is particularly salient or rewarding to someone. So on a molecular level, small changes in the level of dopamine will ultimately first affect potassium channels in target neurons through the stimulation of D2, 3, or 4 receptors. And then fast, large changes in synaptic dopamine, like when dopamine is just dumped in large amounts, will result in transcription in the nucleus through stimulation of D1 and D5 receptors. Also, the relative abundance of the D1-like and the D2-like receptors are different on different neurons. For example, in the dorsal striatum, the basal ganglia, there are separate D2 and D1 medium spiny neurons, and they respond very differently to dopamine. But I'll get back to that later because it's very important. For now, let me talk about the difference between an agonist and an inverse agonist. Many receptors have kind of this basal rate of firing, which means that they are just spontaneously active at some programmed rate. An agonist increases the rate of activity of that receptor. An inverse agonist, when it binds to a receptor, reduces the rate of firing or rate of activity, or it can shut the receptor off entirely. It does the opposite of an agonist. An antagonist merely blocks the effects of agonists and inverse agonists. So when an antagonist binds, that basal rate of firing of the receptor doesn't change. It won't increase or decrease. An antagonist prevents that change. Agonists and inverse agonists result in change, but the change is in opposite directions. But that's not all the kinds of agonizing that can happen to a cell. There's also partial agonists. So a partial agonist is pretty special because it competes with full agonists for the same receptors. It's called a partial agonist because relative to the neurotransmitter it's imitating, like for example, if it's imitating dopamine, when it agonizes a receptor, the increase in activity will be less than what it would have been for that full agonist. So if there's a low concentration of full agonists, if you add a partial agonist, then it could have an overall increasing effect on the total activity of those receptors because there's so few agonists available. But if the concentration of a full agonist is high, then the partial agonist will be competing for that receptor, and it can reduce the total activity of the receptors on the cell because it's not agonizing them as much as the full agonist, and it's getting in the way of the agonist. So if the agonist is in low concentrations and not doing very much stimulation, adding a partial agonist can increase the amount of stimulation. If there's lots of the full agonist and you add a partial agonist, it will decrease the amount of stimulation. Partial agonists are basically raising the floor and lowering the ceiling of the possible receptor activity. I'm going to go uber super nerd here, so if you weren't sure you wanted to keep on listening already, this is a good place to get off. Some neurons, like those medium spiny neurons in the dorsal striatum, they express different concentrations of dopamine receptors. There are the D1 dense neurons and D2 dense neurons. Both can respond to bursts of dopamine, but the D2 will respond more to these small alterations in tonic levels of dopamine. These neurons are part of a system that regulates the flow of glutamatergic inputs from the cortex through this kind of switchboard consisting of neurons in the putamen, globus pallidus, and subthalamic gluteus that ultimately send signals to the thalamus, which itself sends signals back to the cortex. In the middle part where that switchboard is, there's a lot of GABA and a lot of dopamine being delivered. And these inputs are also regulated by acetylcholine and serotonin. So I'm going to get into this a little bit here. In the past, I did a show on the cortico-striatal-thalamo-cortical tract. I'm going to call it the CSTC from here on out. And this was way back in episode 8. That was 29th of January, 2022, if you want to find it. 2 episodes ago, I talked about major dopamine pathways in the brain. So if you want to review that first, I think it could be helpful going forward. I'm going to get even more into the weeds now, in part because I just can't help myself, and because I am taking an advanced psychopharmacology course, so this helps me. This CSTC, that was cortico-striatal-thalamo-cortical tract, is not just one circuit. There are multiple pathways, including like a motor circuit, which are projections from the sensory motor cortex. There's also an associative circuit, which includes projections from the dorsolateral prefrontal cortex and like the lateral orbitofrontal cortex into the striatum and then back again. And then there's the limbic circuit, which includes projections from the limbic regions into the basal ganglia and then back again. I'm going to focus here only on the motor circuit because it's really the easiest to see the effects of. The motor side effects of antipsychotics, things like rigidity, Parkinsonism, tremors, oculogyric crisis, akathisia, bradykinesia, and tardive dyskinesia, are a result of drug-induced dysfunction primarily in the dorsal striatum. So for me, when I'm thinking about this circuit, it makes sense to actually work backward through the CSTC loop. The last part of the loop consists of the thalamus. So the thalamus is sending glutamatergic or excitatory signals back to the cortex. And that's what we're trying to affect in this loop. The whole point of the loop is either to kind of shut off or allow these signals to get through. Depending on what you're doing, for example, you may want to inhibit part of your motor cortex. For example, if you want to flex your arm, you can't really extend your arm at the same time. So this loop helps make things like that possible. One of the reasons our babies take so long to learn motor skills is because this loop is constantly kind of programming itself and reprogramming itself during development. Another part of this, the globus pallidus interna, acts as a gateway to the thalamus. So the thalamus is kind of the end part of this loop sending signals back to the cortex. But before you get to the thalamus, you have to go through the globus pallidus interna. The cells of the globus pallidus interna are able to inhibit the thalamic projections, or not. So there are 2 main ways to get to the globus pallidus interna. One is through something called a direct pathway, and the other is through an indirect pathway. The direct pathway goes directly from the putamen to the globus pallidus interna, and then from there to the thalamus. It's very direct. Neurons of the direct pathway first dump GABA onto the globus pallidus interna neurons, which prevent them from dumping their GABA onto the thalamus. So here's where we start getting deep into double negatives. By inhibiting the globus pallidus interna, which itself inhibits the thalamus is now then free to send its glutamate back to the cortex. It is disinhibited. The direct pathway is disinhibitory. In math, we could just reduce a double negative to a positive. But in a brain, having these double negative pathways is important to be able to fine-tune outputs. The direct pathway in the end disinhibits the thalamus. The thalamus is being inhibited by the globus pallidus interna, and the globus pallidus interna can be inhibited by medium spiny neurons coming from the putamen. The indirect pathway is more complex. Before getting to the globus pallidus interna, the indirect pathway goes through the subthalamic nucleus. The subthalamic nucleus sends out glutamatergic neurons to the globus pallidus interna instead of GABAergic neurons. So this means that when these neurons fire, the net effect is to reinforce that inhibition that the globus pallidus interna is doing to the thalamus. To do this, projections from the putamen first dump GABA onto neurons in the globus pallidus externa, which is next to the globus pallidus interna. And then the neurons in the globus pallidus externa are now inhibited, and so they cannot deliver their inhibitory GABA to the subthalamic nucleus. So the subthalamic nucleus then is disinhibited, allowing the subthalamic nucleus to send its glutamate to the globus pallidus interna, which then sends GABA to the thalamus and inhibits output from the thalamus, reducing the excitatory signal sent back to the cortex. The indirect pathway then can be described as disinhibitory. You could summarize everything by saying the direct pathway helps us do things and the indirect pathway inhibits things. Direct does, indirect inhibits. But simply understanding the endpoints is inadequate to understand why we have motor side effects of things like antipsychotics. So we've gone backwards from the thalamus, and now we're back at the putamen, where kind of everything starts. The neurons that carry GABA from the putamen, along either the direct or indirect pathway, are bathed in dopamine by the substantia nigra pars compacta. The direct pathway is dense with D1 receptors, and the indirect pathway is dense with D2 receptors. Antipsychotics tend to hit D2 receptors with a high affinity, especially the first-generation antipsychotics. Dopamine itself, all by itself, has an overall dampening effect on its target neurons, the D2 neurons especially. The D1 neurons it can actually increase activity of. But for D2, it dampens those down by activating the potassium channels. So blocking dopamine receptors, D2 receptors, will result in an overall kind of derangement of the balance between the direct and indirect pathway, because it's going to kind of disinhibit before the pathway even starts. The result is kind of aberrant signals being sent from the motor cortex, and this can be things like rigidity, torticollis, tremors, akathisia, etc. Now, there are both pre- and postsynaptic D2 receptors that are blocked by antipsychotics. The presynaptic receptors are supposed to tell the neuron that there's already enough dopamine out there, so chill out and start cleaning it all up. But if these presynaptic receptors are blocked, excess dopamine can remain in the synapse. This dopamine is being blocked on the other side, on the postsynaptic receptors, by antipsychotics that are bound to D2 receptors in the postsynaptic part. So they're not really sending signals, it's just there. More signals will then start to be sent through dopamine receptors that aren't being blocked. So maybe like D1 or D3 receptors. But it gets even more complicated than that. Dopamine and glutamate are not the only performers in this delicate little dance. Serotonin and acetylcholine both have roles to play as well. The same medium spiny neurons in the direct and indirect pathway that have dopamine receptors also have muscarinic acetylcholine receptors, and they're regulated by acetylcholine interneurons that themselves have D2 receptors on them. So the acetylcholine neurons stimulate the medium spiny neurons to release their GABA. And just like the medium spiny neuron, their activity is downregulated by dopamine hitting those D2 receptors. This means that while dopamine directly reduces the activity of GABAergic medium spiny neurons, it also indirectly reduces their activity by reducing the activity of the interneurons that dump acetylcholine. D2 blockers, like antipsychotics, then would result also in an excess of acetylcholine release, not just an excess of dopamine release. The medical students and physicians in the audience will remember that we often give kind of hefty doses of anticholinergic agents like diphenhydramine along with haloperidol when we need to emergently calm, say, a violent patient. The idea here is that by giving the D2 blocker, there will then be an excess of acetylcholine. And by blocking the action of acetylcholine, we can reduce the incidence of the extrapyramidal symptoms that Haldol might induce. So it used to be common practice as well to prescribe something like benztropine, also called cogentin, along with antipsychotics. Anytime antipsychotics were given, they just give some cogentin when you're using them chronically. And this was thought to reduce the incidence of extrapyramidal symptoms. But studies have shown this strategy is really not that effective. And it also might contribute to some kinds of cognitive impairment because anticholinergics can impair cognition. Young, healthy folks can withstand a lot of chemical insults to their brain and get better or resist the side effects of things. But people with dementia, like Alzheimer's or Lewy body disease or Parkinson's disease, are much more sensitive to antipsychotics. For Alzheimer's patients in particular, they're often given drugs like donepezil or galantamine, and these medications inhibit acetylcholine esterase. That's the enzyme that breaks down acetylcholine in the synapse. So there's more acetylcholine in the synapse when you give an acetylcholine esterase inhibitor. As a result, when given a D2 blocker that disinhibits acetylcholine release, it results in even more acetylcholine in the synapse. So in the CSTC, this results in extrapyramidal symptoms, especially bradykinesia in patients that take these medications. They're much more sensitive to neuroleptics, antipsychotics. Now remember that the medium spiny neurons are initially getting glutamatergic inputs from the cortex. And glutamate agonizes NMDA receptors there on those neurons. Ultimately, this results in a greater release of GABA by the medium spiny neurons. By stimulating them, you get more inhibition. Dopamine shipped from the substantia nigra should tone this down, but if the D2 receptors are blocked, it cannot. Another way that you could tone down medium spiny neurons, since they're getting excited by glutamate without any way to counter this now, is to give an NMDA receptor antagonist, like memantine. So studies have shown that patients who have dementia and are on memantine are less sensitive to antipsychotics. So if you're on donepezil or galantamine that increases acetylcholine, then you will be more sensitive to the extrapyramidal symptoms of antipsychotics. If you're on memantine, which is blocking that glutamatergic input, then you are going to be less sensitive to those side effects of antipsychotics. Let me say that one more time a different way. Blocking D2 receptors results in excess acetylcholine release into the medium spiny neurons, and also in unopposed glutamatergic input, both of which aberrantly increase GABA signaling in that neuron, and they likely contribute to the development of EPS. The strategy of adding on an anticholinergic agent like cogentin or Benadryl is not really very successful. And tacking on memantine if in patients with dementia can be protective. But we're not just going to give everyone memantine because it has other side effects that we're not anticipating in interactions with drugs. So for Alzheimer's patients already on memantine, it's likely helping reduce the extrapyramidal symptoms. But memantine does not have a clear treatment role in psychosis. So there's one more player in this whole game that I haven't gotten to yet. That player is serotonin. The dorsal raphe nucleus is one of the places where serotonin is produced. Part of that serotonin is shipped to the striatum and the substantia nigra and helps to regulate the activity of the neurons there and even the release of dopamine. This means that there are serotonin receptors on all the neurons that I've mentioned above. In particular, there are 5-HT2A receptors on dopaminergic neurons coming from the substantia nigra. If these 5-HT2A receptors are agonized by serotonin, this will reduce dopamine release. If they are blocked, it would increase dopamine release. So here's why the majority of second generation or atypical antipsychotics come in. Not only are these neuroleptics D2 blockers, but they also block 5-HT2A and often 5-HT6 and 5-HT3 as well. And in addition to this, they're often agonists of 5-HT1A. So here's how all of this is important. Antagonizing 5-HT2A can increase the release of dopamine from the substantia nigra to the striatum, and this can help to tone down those medium spiny neurons. Antagonizing 5-HT2A and 5-HT6 on the acetylcholinergic neurons inhibits release of acetylcholine. In addition, agonizing 5-HT1A will reduce both glutamate and acetylcholine release into the striatum, and also directly reduce GABA release by the medium spiny neurons. So overall, the effects of these second-generation antipsychotics seem to kind of counter the effects of the dopamine, the D2 blockade, in the striatum. And this is going to reduce the incidence of EPS. And studies have shown reduce the risk of developing tardive dyskinesia. When I talk more about antipsychotics in future episodes, I'm going to hit these points again and again. So don't worry if you're not getting all of this right now. I should reinforce right here that reduced incidence of tardive dyskinesia is not no risk for long-term use. So all antipsychotics, other than probably clozapine, carry a risk of tardive dyskinesia. And tardive dyskinesia is what I'm going to talk about next. But before I get there, I want to give that oculogyric crisis I mentioned before a quick shout out. An oculogyric crisis results from abnormal contractions of the extraocular muscles. Most often I've heard of it described as like a deviation of the cornea upwards, like you're trying to stare at your own brain. And this involves distinct pathways in the striatum that actually bypass both the direct and indirect pathway. So instead of stopping at the globus pallidus externa, the globus pallidus interna, or the subthalamic nucleus, there are GABAergic projections from the putamen that reach all the way back to the substantia nigra in the pars reticulata. The pars reticulata is not like the pars compacta. It doesn't produce and ship dopamine. The reticulata is GABAergic, and it tonically inhibits regions in the thalamus and superior colliculus that themselves inhibit unnecessary movements, especially of the eyes. For example, when the eyes need to perform saccades, they need to move together. Projections from the putamen medium spiny neurons inhibit GABAergic projections from the substantia nigra directly. These are sent to the superior colliculus, so it's inhibiting the inhibition of the superior collicular neurons, and this helps to allow the eyes to move together. Disruption of the function of this pathway is thought to be one of the causes of oculogyric crises, in addition to congenital causes, or you might have, strokes or lesions and other lesions in the brain could cause an oculogyric crisis. But now I can move on to that tardive dyskinesia. Tardive dyskinesia is a drug-induced movement disorder, and it's characterized by involuntary repetitive movements. It is most obvious in the face and the tongue, but not isolated there. Someone with tardive dyskinesia may excessively blink, purse their lips, make chewing-like motions, move their jaw sideways, protrude their tongue. They could be rocked back and forth, or they might move their pelvis back and forth. extend their toes, etc. Obviously, like movements like this, uncontrolled movements like this, can result in a lot of social stigma and prevent people from being able to do certain things. Unlike most of the symptoms of EPS that can be present really in other disease states like Parkinson's disease, or could result from brain injuries, tardive dyskinesia is exclusively a result of long-term antipsychotic use. That's the only way it happens. Nothing else causes it. And all antipsychotics can cause it, except for probably clozapine. And that is because, well, clozapine barely touches the D2 receptors. Tardive dyskinesia is called tardive because it's late onset. It's tardy. It's late to the game. The reason it's late is because it requires adaptations of neurons, especially the dopaminergic and medium spiny neurons in the pathway that I talked about. The first adaptation thought to play a role has to do with the number and responsiveness of the D2 receptors. Because D2 is constantly being blocked, one of the things a cell could do to get more input from dopamine is to just make more receptors. Another thing it could do is take the receptors it has and just respond to them in a more sensitive way, make them more sensitive, or like amplify their signal. While there is evidence that D2 receptor numbers are upregulated, especially on the postsynaptic neurons, it actually doesn't appear that receptors themselves are hyperactive or that their signals are really amplified. The main effect that contributes to TD is the upregulation of the number of D2 receptors. But a few other things could happen and also contribute to tardive dyskinesia. Simply upregulating D2 receptors is probably insufficient. The presynaptic neurons also adapt. They could, for example, make and release more dopamine to counter the dopamine blockade. One way to do that is to upregulate the synthesis of dopamine and the vesicles that ship dopamine to the synapses. So you could make more dopamine and ship it faster. But another way to arrive at more dopamine in the synapses wouldn't involve making more dopamine at all, but simply to take the dopamine that's already out there and retake it back and package it and send it back. So there is excess dopamine already in the synapse, and you can repack that excess dopamine into vesicles for release. These vesicles are called vesicular monoamine transporter type 2, or VMAT2s for short. So there is evidence that there's an increase in packaged dopamine, and this can contribute to tardive dyskinesia. The FDA has approved VMAT inhibitors. The names that they've approved are dutatetrabenazine and valbenazine. There's also one called just tetrabenazine, but it's not FDA approved. VMAT inhibitors inhibit VMAT from delivering its dopamine. They're also used to help reduce the choreiform movements in things like Huntington's disease. But VMAT inhibitors do not just decrease the delivery of dopamine, they also decrease the delivery of serotonin and norepinephrine to the synapses. It's not specific to dopamine. So another way, actually, to get a signal through when the signal receptors are blocked and you've tried dumping a lot more dopamine, or at least cleaning up the excess dopamine and sending it back out. You could also expand the surface area of the synapse at the terminal. So this appears to happen through adaptations of the presynaptic neurons. The contact area just kind of changes shape. It can have a kind of like donut or horseshoe shape associated with it, and it can possibly even split into what appear to be kind of two separate synapses. They have like a discontinuous area between them. When observed in animal models, like these synapses were termed perforated synapses because of their appearance. The process of making perforated synapses has been called maladaptive synaptic plasticity because, well, in the case of tardive dyskinesia, the end result is dysregulated signaling, both in the presence of and during withdrawal from D2 blocking agents. So here's a summary of what giving D2 blockers chronically might do to contribute to tardive dyskinesia. First, the number of postsynaptic D2 receptors will increase. The primary way to treat this is just to keep giving someone the antipsychotic, because if you take it away, if you withdraw them from the antipsychotic, this will cause tardive dyskinesia symptoms, simply because there are just way more D2 receptors now. Second, more dopamine is made available because it's not being used up. So it's just repackaged into these VMAT2s and shipped back to the synapse. You can treat this by giving the VMAT inhibitors, which slow the release of dopamine, but also of serotonin and norepinephrine as well. Finally, the synapses themselves have adapted. They've changed shape and in the end kind of increased their surface area. And so there's not much that can be done about that. Once these adaptations have happened, you can down-regulate D2 receptors, sure. But once the synapses have changed shape themselves, that is hard to undo. Many of these changes are permanent. And so about a third of patients who develop tardive dyskinesia have it for the rest of their life. It's irreversible. I encourage the listener to go to YouTube and type in living with tardive dyskinesia and see what you find. So this episode is as long as it needs to be for now. In the future, I'm going to draw on the things that I've said here, and I want to finally talk more about the specific antipsychotics and, for example, which ones have higher rates of various kinds of side effects and how their affinity for dopamine receptors versus serotonin receptors matter, or why things like partial agonists can appear to, at times, act like antagonists. But until next time, I am Dr. O, and this has been an episode of Psydactic Residency Edition.